Dear chairs, dear colleagues, welcome to my 9th progress report. I would like to present my PhD topic, the novel treatment approaches in penile cancer. My name is Judit Vargha. I'm a urology and andrology specialist. I work at Semmelweis University in the Department of Urology. My mission is to search for a more effective treatment for advanced penile cancer patients and thus improve their life expectancy. We have 3 topics related to penile cancer. The first one is a meta-analysis. The second one, the pencil study, is an international survey. And the third will be a registry analysis. My first topic is comparing efficacy and safety of immunotherapy with chemotherapy in penile cancer patients. As a background, I would like to highlight that penile cancer is a real and very aggressive malignancy. The incidence in general is low, but it's notably higher in underdeveloped countries. The 5-year survival in advanced cases is only 16%, and unfortunately most patients seek medical advice late when the tumor is already at advanced stage. For these patients, the therapy after the surgery is chemotherapy, but chemotherapy not an effective treatment. We know that more than 95% of penile cancer are squamous cell carcinoma, and this kind of carcinoma has been effectively and safely treated with immunotherapy in dermatology for several years. And that's why we aim to investigate the effectiveness of immunotherapy in penile cancer. Our question was, is immunotherapy more effective and safer than chemotherapy in penile cancer patients? Our patient population is patients with penile cancer for whom we compare efficacy and safety of immunotherapy versus chemotherapy. And our hypothesis is immunotherapy is more effective and safe than chemotherapy. The implication of our study would be to introducing immunotherapy into daily practice for penile cancer patients to improve quality of life and prolong survival. We found more than 4,000 articles in 3 main databases. Our search first domain contains the condition, penile cancer, whereas the second contains therapeutic options, immunotherapy and chemotherapy. After the selection process, we found 54 articles and 3 more with citation search. And before I present you the results, I would like to highlight we use single-arm studies. We extracted the data from Kaplan-Meier plots. So we use estimations of individual patients' data, and we collected chemotherapy and immunotherapy results parallel, and in the end, I will show you, we compared it in an indirect way. So our first result is overall survival probabilities in immune checkpoint inhibitor therapy in 4 time points. And as you can see, the survival probabilities is decreasing with time, but the main findings or study is there's a big difference between the trials, with the two trials which use the immune checkpoint inhibitor therapy as a first-line therapy and with chemotherapy. Our second outcome was the progression-free survival probabilities in immune checkpoint inhibitor therapy in the same time points, and we can see decreasing survival probabilities, but maybe a slighter wider difference between the first-line immunotherapy and the further settings. This is the results of the chemotherapy arm. We can do an indirect comparison. We can do statistical comparison because the different arms. But as you can see, immune checkpoint inhibitor therapy is effective, and it's promising and hopeful to treat penile cancer patients. And we have few subgroup analyses. The main findings of the subgroup analysis is the PDL positivity of the tumor tissue. We expected that if the tumor has higher PDL expression, the immune checkpoint inhibitor therapy have higher effectiveness, and we can see difference between our subgroups. So the limitations of our study, we use single-arm retrospective studies to the analysis. We have very low number of patients, and the patient's population, the treatment protocol, and the stage of the tumor was very heterogeneous. The strength of our study is this is the first meta-analysis in the topic, individual patients that are available in the majority of the immune checkpoint inhibitor articles, and this is the largest study to date in the topic. So we can conclude that immunotherapy for advanced or metastatic penile squamous cell carcinoma is an effective and safe treatment. For daily practice, we recommend to consider immune checkpoint inhibitor therapy as a first line, preferably combined with chemotherapy and with previous PDL expression screening. And for further research, we need more studies, prospective settings, to directly compare immune checkpoint inhibitor with chemotherapy and with combination therapy. And it is recommended to search for prognostic factors and markers to investigate which patient population will benefit from this therapy. This is the status of our first topic. We are in the article writing phase. My second topic is investigating the effectiveness and safety of penile cancer immunotherapy versus chemotherapy, the PENSIL study. This is an international survey. As I mentioned, penile cancer is a real disease. The 5-year survival is very poor. And in dermatology, squamous cell carcinoma has been treated several years with very good results. And in urology guidelines, immune checkpoint inhibitor therapy just mentions with early evidence and promising clinical activity. So we decide to collecting patients' data who get immune checkpoint inhibitor therapy as a first-line therapy. And our question is, immune checkpoint inhibitor therapy effective and safe in penile cancer as first-line therapy? Our PICO framework is identical with the first topic. And our clinical implication would be to introduce immunotherapy as a first-line treatment for penile cancer patients to improve quality of life and prolong their survival. We are planning retrospective data collection from 2018 when the FDA approved immune checkpoint inhibitor therapy in skin cancers. And we will sending our questionnaire to all centers worldwide where treating penile cancer, and we will collect chemotherapy and immunotherapy results in different sheets, and after we will compare the two therapeutic arms. And we are assessing the changes in treatment habits, comparing the effectiveness and safety of different immune checkpoint inhibitor agents, the combinations therapy, and the gold standard chemotherapy. And we are searching for prognostic factors and markers. We are finalized the questionnaire and the study protocol, and now we are waiting for the approval of the ethical committee. Our third topic will be to investigate the reasons for prolonged denial in patients with penile cancer. This will be a registry analysis. I mentioned in the first topic that penile cancer patients seek medical advice late when the tumor is in advanced stages, and this patient's population typically has low social background and lower level of education. And through our penile cancer registry, we aim to identify the high-risk patients based on their social backgrounds. Summarizing our topics, the first one we want to submit this summer, the second one in the next year, and we are planning to start the third one in this year. And I would like to thank you for your attention with a quote from Terry Pratchett: "It doesn't stop being magic just because you know how it works."
Thank you, Judit, for your excellent presentation. I'm Loretta from the OBGYN Urology Group. And my question would be that, do you look at this PDL expression in the daily routine? Or
Yes, thank you for your question. It would be very good if we check every patient PDL expression. In daily practice, we can't because the therapy not in the guideline. And for example, in case in bladder cancer, we can ask the pathologist to check it because in bladder cancer, we can use immune checkpoint inhibitor. And most of the articles present this PDL expression, but with a very low number of patients. Nearly 20% of patients had PDL expression profile.
I'm Renata Árok from the dermatology group, and I congratulate you for your presentation. I have a question regarding to your first project. What kind of concrete agents were investigated in the articles?
Yes, thank you for your question. As I know, in dermatology are used semiplimab. In these studies, every study used different immune checkpoint inhibitors, semiplimab and everything, and some articles use EGFR inhibitor, and so it's not one agent, and we don't have enough data from different immune checkpoint inhibitors to compare its effectiveness. But with our second project, we hope we will have enough and we can compare them.
Thank you.
Congratulations to very nice results. I would like to ask regarding, we know that immune checkpoint inhibitors have many side effects and quite large toxicity. Do you have any information about the safety outcomes of it?
Yes, thank you for your question. And we collected the adverse event of immune checkpoint inhibitor therapy in a table. The publication type was very heterogeneous in the articles. We made subgroups, hematology, skin side effects, gastrointestinal. The most common was the gastrointestinal side effect, followed by hematological. And the most important, it contains 346 patients' data. And the most important, there were no grade 5 adverse event, so nobody died because of the therapy, and only in 40 patients they stopped the therapy because of adverse events. So the adverse events are manageable in this therapy.